Hello, everyone. This is Jessica Rial with Southern Pelvic Health, and I am here for our provider spotlight today with Dr. Marc Greenstein from Advanced Urology. We started this provider spotlight series and I hope to introduce you, our community, to some of the incredible practitioners in the area who specialize in working with various pelvic health conditions. So, Dr. Greenstein, I am so grateful to have you here today with me. So, thank you so much for your time. I really, really appreciate it.
Absolute pleasure. Thank you, Jessica. Thanks for having me.
Yes. And so I've been working with Dr. Greenstein for probably about a year and a half. And we have worked together helping many people with pelvic pain conditions. And all of the therapists at Southern Pelvic Health have been working with Dr. Greenstein. And we just have been consistently so impressed with the care that you provide. And so we're really grateful because as we'll discuss in a little bit, it can be challenging sometimes for people dealing with pelvic health problems to find high quality care, particularly with people struggling with pain. So
Sure.
thank you for being a provider who is providing great care. We really, we really appreciate it. And our patients do too.
It's all good. It's all good.
Well, so tell us a little bit about you and your background and how you started working with people with pelvic floor conditions.
All right. So I'm a osteopathic physician. So that's I think a very important key when it comes to not only being a urologist, but being a physician as well. So in other words, when I went to med school, I didn't just learn what Flomax does and what estrogen does and what this hormone does and what this stomach, all the organs and things like that you go through medical school. I also learned about osteopathic manipulative medicine, about realigning the body, keeping things oriented,
Mhm.
muscles, nerves, all that stuff. So I have that background. But then I went on and I did a traditional residency in urology. And, I operated constantly and I ran the hospitals and that's what you did as a resident.
Mhm.
And then when I went into practice in 2003, I was starting to see people that were coming in that no one had answers for. And the classic story would be a guy who was diagnosed with prostatitis for 6 years. He's been on 20 different antibiotics, but the symptoms keep coming back. And there will be a woman with symptoms of it hurts during intercourse and my doctor gives me antibiotics and it doesn't get better, or I get recurrent urinary tract infections and they keep coming back after antibiotics. And so I started dabbling in a couple of things. And then one year, going back to probably around 2008, I had a female that was just having a lot going on. She was born with something called a horseshoe kidney. She was having pelvic pain. She was having recurrent infections. She was having vulvar pain, dyspareunia or pain with intercourse. And I dabbled in a couple of things. And I said, you know what? We need you to see someone else because there's more than meets the eye here. And she went to a urologist in Philadelphia named Christine Whitmore, who is pretty well known in what we call the female urology world. And she saw Christine, and the patient came back with a binder, okay, like a book of what it's like to go to, I guess, what you'll call the Whitmore Clinic.
Mhm.
And I took the binder and I'm like, I could do that. I could do that. I could do that. I am not doing that. And I literally taught myself what was going on because when I finished residency, there was no training in this. No one
Yeah.
learned this.
Because it's not
Uro,
typical in traditional urology training, right?
this is not typical for any training.
Yeah.
And so the urologist didn't know it. The urogynecologist didn't know it. I mean, the urogynecologist or the advanced gynecologic surgeons knew endometriosis and endometriosis surgery. But you have to remember, this is the beginning of laparoscopic surgery. This is pre-robotic surgery, when all that stuff was going on.
Yeah.
We knew how to handle interstitial cystitis, but we still didn't know a lot about it. This is 20 years ago.
Mhm.
And
Mhm.
so I started using these techniques. I said, okay, clearly we need a pelvic floor physical therapist. And in New Jersey, there was like two. Okay.
Mhm.
That's because I used to practice up in New Jersey. And I started dabbling in the world of compounding medicine. And I was like, holy cow, this works. Patients who are coming back, with this symptom, that symptom, this symptom. and getting them into the right hands and getting the right compounds and medications, we were fixing people.
Mhm.
And this is when, I mean, no one was sending to pelvic floor physical therapy. There was no self referrals for it. I
Mhm.
mean, this, we're talking new stuff. And so I was able to just build this practice, start trying this, trying a different medicine, trying this. I would talk to the pharmacist, like, what do you think of this? And I would really get these patients into much better conditions.
That's awesome.
And it was going great. And I was building a name in New Jersey as this is the guy to go to.
Mhm.
And but then I moved and I came to Atlanta, and it's been awesome ever since. And one of the very first things that I did when I got here almost 3 years ago, is I literally went door to door, or I called all the pelvic floor people in the area. And I said, "Hi, I'm Marc. This is what I do. I'm going to make you busy." And, and then here I am.
That's awesome.
And so I don't do the traditional, here's your antibiotic. I don't do your traditional, um, it must be a hernia, go see a general surgeon, or it's clearly your hip, go see your orthopedic surgeon. It's not that. It's
Mhm.
muscles and nerves, and mostly a lot of times. And that's why you are the magicians. I call you guys the magicians. And so then, if I can continue,
But not
about
magical.
no, 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 magical, trust me. Trust me. Um, then about 4 years ago, I said, you know what? I'm self-taught. There's no fellowship in this. No one taught me this. I just read and paid attention, and I listened to my patients. And I said, I better make sure I know what I'm doing. And so I went to the International Pelvic Pain Society meeting that Amy Stein put together.
Mhm.
I think I was at the second or third one ever. It was in the DC area. And I'm going to these lectures. And the way I describe it is, there were 700 people at the conference. 650 of them were pelvic floor physical therapists. A mishmash was gynecologists that specialize in endometriosis, and then there was like a PhD, a urologist, and a couple of other things in there. And I listened to all these lectures, and I'm like, I'm doing that, I'm doing that, I'm doing that, and I'm like, good job. And so, and I'm not trying to make myself proud here. It
Oh,
just
that's great.
confirmed
Yeah.
that, okay, we're doing well here. If the guy from Johns Hopkins is publishing this and I'm doing that, perfect. If the
Yeah.
guy from UCLA or girl from UCLA, woman, excuse me, from UCLA is publishing that and I'm doing that,
Mhm.
perfect. Got it.
That's awesome.
And now that I'm in Atlanta, I'm trying to teach it to my colleagues so that when they have a person that comes in, it's like, oh, my testicle hurts. I went to the urgent care clinic. They gave me antibiotics. I saw a urologist. He said, keep taking the antibiotics. No,
Yeah.
yeah.
Yeah, that's I love that. I love hearing your journey. I hadn't heard about all that before, and I think that that's it's amazing that you were kind of pioneering and figuring this stuff out, and with your patients and research and everything. So that's really awesome.
Yeah.
I want to touch a little bit. One of the things you were talking about, you said we're magicians, which I would say I actually tell patients that we don't have magic wands. We partner with them and we work together to try to help things.
You do have wands.
What do you say?
You do have wands, the Theravon.
Oh, but um, but I think oftentimes what we find with so many different conditions is that collaboration really is where patients tend to do well, to where it's a combination, I mean, and I find that what we do oftentimes, if we're working with someone like yourself, and patients can have the right medical support along with that, where it's the compound, other medications, et cetera, they tend to do better. And I was hoping you could talk just a little bit about that piece, and kind of the approach that you tend to take with working with people, particularly with pelvic pain, because I see sometimes with patients that when I first make the recommendation for them to go see someone, and say, hey, we may need to consider something else, like a compound, like a medication that they might be able to offer you, because I think that's going to help you get better faster. Some patients will feel a little bit worried about that and feel like, well, but if I do that, then how are we going to know what's working? And they want to kind of try one thing at once. And so I'm hoping you could talk a little bit about that.
So a couple of comments on that. So one of the things that I very often tell patients is that we may never find the cause of your pain. And it would be a great injustice to just say that you have a diagnosis. Okay, you have pubic arthritis. Okay, you have, vulvodynia. You
Mhm.
have Greenstein vaginal syndrome. I mean, a
Is
lot
that
of
is that going to be a syndrome now?
no, no, no. But unfortunately, patients feel like they have to have a diagnosis.
People want answers.
And I don't, they want an answer. And I
Mhm.
just say, listen, you don't feel good. We're going to make you feel better.
Mhm.
End of story. However we get you there, it's okay. But we're going to get you there. And so as far as like a multimodality approach or a multidisciplinary approach, that's huge in this. And
Mhm.
so when I see patients for pelvic pain, as I'm talking to them, and the way I handle a consultation is I let the patient just talk. I'm like, okay, ready? I want the timeline. Talk and go. And then I'll interrupt them a few times because I'm not very good at typing and I have to erase a lot. And I may want to double back on something and use what they're saying to figure out where they're going with a sentence or two. But as they're talking, I am going to be like, okay, all right, who's getting involved in this? Because usually there's multiple players getting involved with some of the patients with a lot of pelvic pain.
Mhm.
So, for example, a woman that's coming in with 10 years of vaginal pain, pain with intercourse, interstitial cystitis, they need me, they need pelvic floor physical therapy, they need compounding medicine, they may need a psychologist, they may need someone to help out in here with their pain syndrome because it's a full body approach. And one of the things that was fascinating that I learned years ago was that if you took an MRI of a person with no pain and you did an MRI of a person in pain, their MRIs light up differently in how the hormones of the brain are moving about.
Mhm.
And that was like, holy cow, like that was huge for me. And so I may need a GI doctor if they're having bowel syndromes or bowel symptoms. I may need a urogynecologist. I may need their internist or family doctor to help out and give them, get them through this problem. So it's a multidisciplinary approach, and that's I think very very important to just say, here's your bill, see you in 3 months. Tell Jessica I say hi. Does no, they need more. I saw a person the other day. He needs a psychologist. He needs a psychiatrist, and they're different. Okay.
Mhm.
He needs pelvic floor physical therapy. He needs physical medicine and rehab. And we can talk about people like Yogita Taylor, who's new in town, which is just
Yeah, she's wonderful.
awesome,
Yeah, she's
awesome.
great.
Um, I mean, he needs a full clinic.
Mhm.
He really does.
Mhm.
So that's a very important thing.
Yeah, yeah. I love that. And I want to talk just a little more about that psychology piece that you were talking about, because that is in my world with what we do as pelvic floor physical therapists, people often think of our treatments as very pelvic floor focused because that's where we have a lot of extra training and different things like that. But part of what we do is try to help people with understanding about pain and about pain being an output of their brain and how their brain responds to threat, and helping them learn how to decrease threat in their bodies. So it's a huge piece. And sometimes when people first hear the concept of their brain being involved, that also is something that can make people feel a little bit like, whoa, because they worry that someone's saying that this is in my head and you don't think this is
Yeah.
real. And I was hoping you could talk just a minute or two more just about that piece, because as we know, pain is, while we know our brain's connected, it doesn't mean that their pain is not a real thing, or that their brain is making it up or anything like that, right?
Right. So I hate when patients say to me, it must be in my head, or this doctor told me it's in my head. Well, I mean, of course it's in your head, because if you're having pain and you have hormones in your brain called serotonin and epinephrine and norepinephrine that are misbehaving, we need to get those adjusted.
Mhm.
And so that's why in some patients, they need someone to just talk to them. Talk. It's the
Mhm.
same thing as a soldier that's wounded or beat up from battle and they have PTSD. It's the same thing. I saw someone today with that. He's got PTSD, and his symptom of PTSD is pelvic pain and erectile dysfunction. He
Yeah.
needs a physical therapy. He's going to need one of the pelvic floor people
Mhm.
soon. I'm getting him there, but I don't jump right away sometimes.
Yeah.
Um, and so if there's a misbalance of those hormones, we have to figure out how to get those hormones balanced. In some people, we have to use medications. We have to use things like Cymbalta or duloxetine, old school medicines called Elavil, which is amitriptyline.
Mhm.
Sometimes it's just Prozac or Zoloft. Sometimes it's just we need Valium. We need Valium. We need
Yeah.
to calm down. And on top of someone working on the coping skills, working on the emotional
Mhm.
aspect and doing behavioral therapy, on top of a pelvic floor physical therapist teaching someone breathing techniques and muscle
Mhm.
relaxation techniques and all the wonderful stuff that you do.
Mhm.
And then I just reinforce everything and say, good job.
Mhm. That's good. The quarterback, right?
Well, I mean, that's my line. I
Yeah.
tell people you need a quarterback. It's the same thing I tell my prostate cancer patients. They need a quarterback.
Yeah.
We're going to either use the wing, the receiver for radiation, or we're going to use a linebacker for this, or we're going to, and I have my go-to people.
Yeah, yeah, that's awesome. I think and I think that that's a piece that oftentimes for people is tricky to figure out where to start. When a person is dealing with pelvic pain or a new onset of type of a pelvic pain, or they start having incontinence and they're trying to figure out where do I go, because the reality is you just mentioned all these different providers who often are involved, and I think for
Mhm.
patients sometimes they look and they say, okay, so where should I go? Should I see the urologist? Should I see the gynecologist? Should I go talk to my family doctor? Should I
Yeah.
what would you recommend if someone is just trying to kind of figure out their navigation of where do you start?
It,
Um,
well, it's a little challenging because one, we would hope that their family doctor, internist, or even the gynecologist
mhm,
is educated about what goes on. And they don't just say, "Oh, you have leakage? Oh, here's an antibiotic.
yeah.
Oh, you have a little discomfort? Oh, here's an antibiotic. Or
Hmm.
here's a steroid pack." The only thing we can do is just educate those providers, but that is really hard to do.
Hmm.
That's really hard to do. The second challenge is the internet. And when I went out in residency, internet was kind of fresh. There
Hmm.
was a couple, kind of new, and still new, not that new, but kind of new. And it's much more robust. And the internet could be good. The internet could be bad. The internet could be wonderful in the sense that you can have a patient that can type in pelvic pain and urine leaks, and then they get urology websites, they get pelvic floor physical therapy websites, and they get nice things like that. The dilemma with the website is that they're also going to get you're going to die and you have
Hmm.
kidney cancer and don't go make any long-term investments. And
It's
so
true.
it's
It's
true,
so true.
totally true.
Yeah.
And so then you have patients who are self-referring because one, they don't know. No offense, I'm not trying to be rude, but they just don't know, and they shouldn't know because they're not doctors.
Hmm.
And so they then start going down a path of seeing all these different people that probably have no idea what to do.
Hmm.
And unfortunately, I'm going to be a little rude here. Doctors feel like they have to give an answer. And so, for example, the person I saw who said to me, "Well, I must have neuropathy." I'm like, "Who said that? Like, where'd that come from?" You know? And so, they get pushed down these roads of error and misguidance. Not to say that I know everything, but when we have a person who is not feeling good, and we can kind of whittle down what's happening and get to the source, then we can hopefully get them into the right hands, and at the same time educate. In
Mhm.
other words, send a quick message out to their primary. Hey, I saw Joe today. It's not epididymitis. He's got pelvic floor dysfunction, and this is what we're going to do. And hopefully that provider would say, I'm going to do that for the next person,
Mhm. Mhm.
and then the next person. And then they're going to tell their partner, and then they're going to tell their neighbor, and you just hope that it keeps building. Because, like I told you, when I first started, there was no pelvic floor physical therapist. I mean, there was no one. Now it's, look at all this. It's wonderful.
Mhm.
And even now, I'm seeing the younger people coming out and training,
Yeah.
that are being much more proactive in using this approach. So specifically, on Twitter, because I do a little bit of that, there was a doctor from somewhere that said, I must be having the ball pain clinic today. So testicular pain clinic today. What do you guys do? And a bunch of people chimed in. And you know what it was? Pelvic floor physical therapy, pelvic floor physical therapy, pelvic floor
That's
physical. I mean, that,
amazing.
which 10 years ago, that
Never.
never would have happened. Never.
Yeah.
Yeah. And
That's
so
awesome.
it just shows that they're realizing what we can do.
That's amazing. It's interesting, I think, with social media now, and we also see both sides of the coin, right? Like the very good thing is that information is a lot more accessible too.
Mhm.
And I think even providers, like I'm on Instagram and I'll see providers will be posting things on Instagram and putting information out and but learning too, along the ways and questioning the way things are done. And there's a lot of positives, I think, to that.
Yeah.
So very cool. Well, let's talk just along with the ball pain. Let's talk about pelvic pain in men because I teach courses in pelvic floor and one of my fellow faculty members is a guy, and when he gives a lecture about male pelvic pain, he always starts it by saying this is one of the very few areas in medicine where men are an underserved population.
Mhm.
Because when you look at pelvic pain, there are often a lot of challenges with guys in terms of navigating dealing with pelvic pain. I think that um, they don't tend to they tend to get misdiagnosed often, as you kind of alluded to, even talking about the antibiotics pieces, and so I think that, and from pelvic PT standpoint, I'll say there are far less pelvic PT practices that treat men than there are who treat women. I mean, we're fortunate here at Southern Pelvic Health. All of our PTs treat all people, and but that's not the same for many
Mhm.
practices.
Yeah.
Can you talk just a little bit more about the journey that men go through? Oftentimes what we see is, they start having this perineal pain. Maybe it's pain into the testicles. Maybe it's pain just in the perineal area around the anus and stuff. And they usually start with this prostatitis diagnosis. I've seen men put on 6+ rounds of antibiotics and they ended up researching and finding something different. So if you can talk to us a little bit about that and about any advice for them in terms of navigating that and navigating that a little more quickly versus, when is it appropriate to do antibiotics and when is it not?
Right. So like I try to teach my patients, teach my colleagues, the history is going to give the doctor the answer. I'm a firm believer in that. In other
Mhm.
words, if you sit down and you just spend a good 5 minutes with a patient and listen to their story and figure out where they're going, they're going to give you the answer of what's wrong with them. And so I'm going to take an example. A patient the other day with 8 years of growing pain, testicle pain, pelvic pain, and nothing works. Nothing. Okay. This is going to sound rude, but the source of his pain is he was molested as a child.
Mhm.
And it is all over him right now. And so when I have a person who has, first of all, on physical exam, nothing wrong with them, and I can't find anything. But when I start talking to them and they start giving me answers, and I'm like, wait a minute, go back. What was that? You had what done and where, and they're going to give the answer. And so I think it's real important to do that. The dilemma with some of these guys is that they go to urgent cares, they go to, busy clinics, and like, oh, burns a little, here, antibiotic. Microscopic hematuria, oh, here's an antibiotic. And so they go down this path, and America is built on antibiotics. It's an absolute terrible thing. And so the only thing I can hope is that the providers and the patients start giving a proper story and listening to the proper story of what is this patient experiencing and where can we go with them.
Mhm.
Now, if a guy comes in and his scrotum, let's be honest, scrotum is red hot and they have a fever, they have a bacterial infection,
Mhm.
right? Antibiotics. If a guy comes in and he's got a low grade temperature, frequency of urination, and a swollen prostate, he's got prostatitis, antibiotics. But if you have a person that says, and specifically for guys, it hurts after I ejaculate, right? I have pain that radiates down my penis. Sometimes it goes back towards my tush. That's not infection.
Mhm.
Okay. And so for that, that's pelvic pain. To me, any guy who has pain with ejaculation, that's pelvic pain. That's muscular.
Mhm.
Because the anatomy is that when guys ejaculate, there's a rhythmic muscular motion. And if those muscles are off, just like the muscles in your neck and the muscles in your back, you're gonna hurt. And
Mhm.
so you gotta go listen to what they say. And sometimes or at least a lot of times, the pelvic exam can be very important. And when I do an exam on a guy who's in pain, I mean, it's a 0.3-second exam of the prostate, like, whoo, okay, that's fine. But then I go pushing on a pelvic muscle and I got to bring him off the ceiling because it hurt that much.
Yeah.
That's pelvic pain.
Mhm.
So I remember when my partner Neil Patel, who is he's robot trained, like all he does is robotic surgery. I mean, that's his thing. And he has a guy in the office. He's like, I got this guy, antibiotics, and we put him on steroids, and he's not getting better. I said, Neil, go in, stick your finger in his tush, go like this on his pelvic muscles, and if he jumps, he's got pelvic pain. Goes in, he's like, holy cow, mic drop. And I'm like,
Mhm.
pelvic pain. Give him
Mhm.
Valium, give him the suppositories, get him to pelvic floor physical therapy. You're gonna have a very happy patient.
Mhm.
That's what it was. Did I
Yeah.
answer your question? I kind of
Yeah.
went
No, no, no.
all over the
No,
place.
no, no, that totally does. That totally does. And I love that piece about really listening to your patients. It was reminding me of when I was in grad school. I had a professor who said to us, he said, if we truly listen to patients, they'll tell you what's wrong with them.
Yeah,
And it's such a simple statement because you're like, oh, of course they'll tell you, but it's so true. You know, my
so true.
favorite thing in the office is when a patient says, okay, there's this thing, you're going to think this is really weird. And I'm like,
Yeah,
tell me everything,
come on,
because
I've
it's,
heard it all.
and it's always something that's really interesting that you're like, oh, that injury that you had, or oh, it was a really stressful year, and you think that maybe that's connected to why you started having this symptom. But I
Yeah,
think, with the pelvic floor muscles in particular, I think part of what makes it trickier for so many providers is there are few muscles in the body that directly impact organ function, and I think that that's where it gets complicated, to where people look at things like urinary symptoms and sexual symptoms, and there's all these other things that have to be considered, but the muscles can mimic a lot of other things as well.
100%. So, I make this little symbol here, and this is what I call the girdle. And
Mhm.
this is all the pelvic muscles coming wrapping into the area underneath the bladder, prostate for men, the urethra, vagina for women, and in the back is the tush. And if these muscles are out of whack, everything above it's going to be out of whack.
Mhm.
And we have to learn how to get these muscles to either coordinate, relax, whatever.
Yeah.
And that's why you're the magician. So you make that better. I'm
Together,
I'm just the
together, we
guy
work
who's
together.
like, I'm just the guy who's like, that's it. It's a muscle thing. Here, go, 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 go.
That's an important part of the journey, though, a
I
very
know.
important part. Um, so tell me, this has been wonderful. I've loved hearing from you, and you have so much insight to all of this. But I would just love, just in terms of wrapping up, if there's one thing that you would want to share to our community, because we have people who are listening who have been are very much in their journey dealing with pelvic pain. Many of them already are doing some of the things you're talking about, or they're doing much better. But then we have other people who follow us online and they're just getting started in their journey in navigating pelvic pain, or maybe they're 6 years into their journey. And is there anything that you'd want to share to someone who's listening?
So I guess a couple of things. One, be very careful of all these antibiotics. Very careful. So if you go and you have these symptoms and your doctor's like, here's antibiotics and here's more say, I'm good. Thanks. Let me go find a urologist. Let me find a gynecologist. Let me figure that one out.
Mhm.
Second is, for the pelvic floor physical therapists, um, I encourage my patients to see someone that only does pelvic floor physical therapy. And I'm not trying to be rude to the other, regular physical therapists out there, but I tell patients, I said, listen, if you go to someone, and I'm very open about where to go. Sometimes it's logistics, sometimes it's insurance and
Mhm.
where they live and stuff like that, and with their work hours and whatnot. But I said, you can't go to someone where their 2 o'clock is a neck, their 3 o'clock's a shoulder, their 4 o'clock's a pelvic pain, and their 5 o'clock's a hip. It's not going to work. You need
Mhm.
someone where their 1 o'clock's a vulvodynia, a 2 o'clock is a male pelvic pain, a 3 o'clock is um, vestibulitis, an interstitial, where all they're doing is this.
Mhm.
Um, and the third thing is hopefully, and I think this will happen, it will at least continue to happen, is we're going to see more and more physicians become in tune to this, and therefore they can say, "Oh no, 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 no! This is muscular. Let's go get to the right physical therapist. Let's get you to a gynecologist or a urogynecologist or to a urologist that works on this."
Mhm.
So that's kind of all that I think of.
I love it. I love it. Very, very good advice. And to add to it, if anytime, and I think you would agree with me, I think anytime you're working with a provider and you don't feel like you're getting answers, or you're not comfortable, or it just feels like your wheels are spinning, you always have the right to seek another opinion
Oh
from
yeah,
someone too.
yeah.
You
Second,
know, and I think that I love your messaging, and this has been so great. I think it's so nice for patients to be able to hear a little bit about this from you, and understand a little bit more about how they can kind of optimize everything for them in terms of handling these types of conditions. So thank you so much for being here
yeah,
with me.
pleasure.
And if a patient is interested in consulting with you, what's the best way for them to get in touch with you?
We're called Advanced Urology. So advancedurology.com.
Great.
We have, we have a phone number, 678-344-8900. And the website's advancedurology.com. And we have
Perfect.
multiple locations
Awesome. And you're
throughout the
in
Bay
Sandy
Area.
Springs?
Huh?
You're in Sandy Springs, right?
So we have multiple areas.
Uh-huh.
Close to you is the Marietta office and a
Uh-huh.
Canton office.
Uh-huh.
Those are Doctors Ostrowski, Lomboy, and Dave, who are very, very good people. I'm in the Sandy Springs location.
Uh-huh.
We have our Roswell Alpharetta location with Dr. Kasabian, Dr. Mullins, Dr.
Mhm.
Radadia, Dr. Farrell's up and coming. And then we have people way east of the city, out in
Awesome.
Snellville, Lawrenceville, and Decatur.
Awesome.
Yeah,
Very good. Lots of options then for people.
it's all good. It's all good.
Very good. Well, thank you again so much for chatting with me this evening. And I very much so appreciate your time.
Great, Jessica. Have a good night, okay?
You too.
Don't work too hard on that treadmill back there.
I don't know about that.